My partner, Sonia Dinizulu, and I, she's a psychologist, we run an interdisciplinary clinic that specifically addresses the mental health needs of children and families who have been exposed or affected by community violence. It doesn't necessarily mean that you have to be injured by community violence or have had a sibling affected by community violence, but have you been impacted by it? Have you heard gunshots in your neighborhood? Have you had a kid in your school have a loss secondary to gun violence? How has that impacted you? We know that it does. We know that it has significant mental health ramifications. So what our clinic does is basically provide a very trauma-informed assessment that's specifically focused on the impact of community violence exposure. And we do a comprehensive evaluation where we emphasize that it's not what is wrong with you, but what happened to you. And then we try to think of interventions that can offset the negative consequences of community violence exposure by incorporating community assets. Some straightforward interventions like psychotherapy, psychopharmacology, but also really thinking about how we can incorporate elements like social prescribing that have been demonstrated to have positive outcomes on traumatic exposures.
I run the clinic for the 3rd and 4th year residents in addictions with a broader conceptual foundation of addictive, compulsive, and impulsive disorders. Well, what I do is a lot of clinical research. We do clinical treatment trials, neuroimaging, neurocognitive and personality assessments in folks. I think the idea that psychiatry has discrete disorders has been, a bit of a sort of a misunderstanding of how the brain circuitry works. And the reason that we include a range of these types of patients in the clinic is that, one, we know that illnesses most likely change over time. So there's actually good evidence that things that start impulsive become compulsive. So if you talk to somebody with a heroin problem, 6 months into it, they look very impulsive, their decision-making is very quick. But 30 years of heroin use, quite frankly, they look very much like somebody with obsessive compulsive disorder. They're very harm avoidant. They don't have that classic impulsivity, and they're much more compulsive. And so this actually the clinic, I see it as understanding mental health problems on a neurocircuitry level as opposed to simply parceling it up under the discrete disorders. The treatments, what I want residents to learn as well is that one size doesn't fit all, that it really needs to be tailored for the individual, and that may mean both FDA-approved medications for problems, as well as even off-label use, if one can understand and have a sort of a theoretical understanding of why this person has problem X, and then the comorbid problems A, B, and C as well. I want them to understand the range of treatments, both psychosocial interventions, medication treatments, and then what they can access in the community, and even emerging treatments that may be less evidence-based, but may be the treatments for the future.
Most of my work is centered around running the ECT service here at University of Chicago. And one of the bigger projects that I'm currently working on is developing an LGBTQ plus specific clinic for psychiatry, which will include patients from all walks of life, all ages, predominantly adults with LGBTQ focused issues around mental health. And as a part of that, we're also starting a multidisciplinary team of providers amongst the hospital from different areas of the hospital, including endocrinology, surgery, and we're looking to essentially create a first multidisciplinary team here at U of C Medicine focusing on gender health and sexual health, with focus on adolescents all the way through young adults. And so this has been something I've been working on over the last couple months, and I'm really excited about. I think it's going to be a unique opportunity for residents to train in, and I'm really excited to be able to serve this patient population.
Psycho-oncology is a very interesting area of medicine and psychiatry interface for any number of reasons, but I think primarily because often patients who receive a cancer diagnosis are going about their day and this arrives out of nowhere. And I have found in my work that if those patients have their psychiatric needs addressed proactively in the beginning, they often can sort of regain a pre-morbid level of functioning pretty quickly. So it's incredibly rewarding work. Plus, cancer is an equal opportunity kind of deal, so I sort of feel it can happen to anybody. And it's also, I think, an area of huge research and development, and often we find that things that ultimately get adopted throughout the medical world are rolled out first in cancer. And so it's a good and exciting place to be in terms of innovation.
I'm specifically interested in that intersection between trauma, personality, and the brain. And to some degree, the clinical work and research work go hand in hand, although the methods are quite different. With my interest in trauma came an interest in what we call secondary trauma, which is the traumatic experiences of healthcare workers. And we started this work not with COVID, but rather with the opening of our Level 1 Trauma Center in 2017. And we learned some really useful lessons then about how to address this in healthcare workers who are what we would call online, so not on break, not on vacation, but at work. And so when COVID hit, it's like, in some ways, it's like we got a dress rehearsal for what was to occur. And essentially what we did is apply some of the approaches that have been used in disaster psychiatry to the healthcare population, or the healthcare worker population. And so in that work, what we did is we viewed healthcare workers as a community. And previous research in disaster psychiatry has revealed that approaching the community like a clinician doesn't seem to work and can actually backfire. But what does seem to work is addressing the community as if it were a community and strengthening things that are already there. And so to that end, what we did is we created a very brief training program that doesn't really feel like psychotherapy, but uses some basic principles from trauma therapy and team building. And so what we do, it's a peer training model. In 30 minutes, we train clinicians to train each other, including medical students and residents. And with that model, we're able to spread an intervention really quickly through the organization. Residents have been really integral to this process, both in helping design the intervention and in some ways simplify it. A lot of our conversations were about how do we make this even simpler. And so, it's impossible to say the true impact of interventions like this, but they're well received and the institution seems to benefit from it. So we can say to some degree, we're better prepared for whatever comes next.
Forensic psychiatry is a subspecialty of psychiatric care, and it is something I actually didn't even know existed until I came to residency here at the University of Chicago. And while I was here in my second year, I realized that it was a specialty that I even had access to. And I learned a lot about it through the APA. And it's a really interesting specialty in that you work at the intersection of psychiatry and the law. So any way in which psychiatry interacts with the law kind of becomes your specialty. So the type of work that I do a lot of work with the Public Defender's Office and with the Federal Defender's Office, working with patients who have committed crimes, maybe because they were very psychiatrically unstable, either very manic or very psychotic. And we work with them to determine whether or not they were psychotic to the extent that they didn't understand that what they were doing was wrong. So we do like not guilty by reason of insanity cases. We do things like determining whether someone is capable of standing trial, because they have to be able to understand what a trial is before they can do that. I do a lot of work in testamentary capacity cases, which is on the civil side of forensic psychiatry, so working with attorneys whose clients have maybe been named in a will or were excluded from a will of a family member, and trying to work with them about whether or not their family member had dementia to the extent that they didn't know what they were doing when they wrote their will, those sorts of things. You can do malpractice cases. There's really just such a wide variety of different things you can do in forensics. We have a course for forensic psychiatry where we kind of learn the ins and outs of forensic psychiatry, and in the 4th year, interested residents have an opportunity to work with me on cases. They can get the opportunity to write up a forensic report. They get to see what an evaluation looks like, a forensic evaluation, and they can learn really as much as they want to about the specialty. We have a couple of residents right now who are interested in going into forensics, and so we're starting early in their 2nd or 3rd years even, taking on cases and working on learning how to write reports and how to testify in court.